Hello, I'm Adrian Gowdy, and in this talk we're going to discuss biliary ultrasound. First of all, we're going to quickly run through some of the clinical background as to why we may wish to perform a biliary ultrasound. Then we're going to talk about the anatomy of the biliary system, and finally discuss how one actually performs an ultrasound of the biliary system. So, as you realise, biliary disease is common in our society, and in the acute setting it usually presents in one of three ways: with pain, with jaundice, or with sepsis, and it may be a combination of these. So to start with, let's talk about the patient who presents with pain. Now, biliary pain may have a classic presentation, and when the patient has this, it may not present much of a diagnostic dilemma. However, it's often atypical. When it is typical, the pain is steady, it's not colicky. It's present in the right upper quadrant or the epigastric region. It may be associated with or brought on by eating, particularly a fatty meal. And the pain often radiates to the tip of the right scapula. It should be noted that simple biliary colic should not be associated with fevers though. Now when this happens, and it's classical, then the diagnosis is usually quite clear. However, the differential for patients who present with epigastric or right upper quadrant pain is very large. And when they present, we often think about acute coronary syndromes or myocardial infarctions. Gastritis or esophageal spasm can present in a very similar way. Pancreatitis may mimic biliary disease and in fact may also be caused by biliary disease. Hepatitis, of course, can cause right upper quadrant pain. Appendicitis early on in the clinical picture can be mistaken for biliary colic. Pneumonia, right-sided pneumonia, is often mistaken for biliary disease because of the pain with deep inspiration. Renal colic or pyelonephritis, classically the pain is a little more posteriorly around the flank, but it may be confused with biliary pain. And of course, musculoskeletal pain of the right lower chest or upper abdomen can mimic biliary disease. Now, when a patient also has associated fever or signs of sepsis, then this suggests that it's not simple biliary colic, but the patient has now progressed to have cholecystitis. And the pain is usually very similar to the biliary colic, but now the patient will also complain of fever. They will classically have a Murphy sign, that is tenderness in the right upper quadrant that will cause the patient to catch their breath when they take a deep inspiration. As the patient breathes in, the gallbladder descends beyond the costal margin, and the pressure from the examiner's hand or fingers will cause pain at that point. And as the disease progresses, the patient may well develop features of systemic sepsis. If the patient then also develops jaundice, then this suggests that the picture is now one of cholangitis. So that is generally an obstructed biliary system which now has superseding infection. One of the things to remember in these cases is that, particularly in elderly patients, that the presentation may well be much more of a generalized septic state, up to and including septic shock, without many features to specifically point to the biliary system as the source. The patient may not have right upper quadrant pain. They may not be jaundiced. They may have some mildly abnormal liver function tests, but that may be due to the generalized septic state. And so it's always worth bearing in mind in the patient who's got septicemia of unknown origin that the biliary system may well be the source. Now, in the patient who presents with jaundice, we classically divide these patients into two groups, those with obstructive jaundice and those with non-obstructive jaundice. Now, there are features of the history that can help distinguish between these two, such as change in the colour of the urine and the stool, and we often will rely on blood tests to help, but these are not necessarily definitive. Classically, we will look at the ratio in the rises of the alkaline phosphatase versus the transaminases, and classically in obstructive jaundice, the alkaline phosphatase rises in a much greater proportion than do the transaminases. However, in cholestatic hepatitis, due to non-obstructive causes, you can get identical biochemical changes. And some of the causes of this are sarcoidosis, drugs, tuberculosis, and primary biliary cirrhosis. It should also be remembered that transient obstruction from choledocholithiasis can cause rises in the transaminases up to 20 times their normal levels. And that if you only look at that ratio between the alk phos and the transaminases in that setting, you'll suspect that this is actually a non-obstructive cause, when in actual fact it's due to a stone obstructing the common bile duct. So because of this, we often rely on imaging to try and distinguish between these different groups of disorders. And ultrasound is generally the modality of choice for biliary imaging. And this is for a number of reasons. One is the high accuracy. Secondly, if the patient's particularly unwell, we can move the ultrasound machine to the patient. Thirdly, there's no ionising radiation. And fourthly, it's relatively cheap compared to some of the other imaging modalities. It should also be remembered that for stones in particular, ultrasound is more accurate than CT, because stones may well be isodense on CT and therefore missed. CT, however, obviously does have a role, and it will generally depict the bile ducts and particularly tissue masses better than will ultrasound. If the answer is still not clear, then MRCP may be used, and occasionally more invasive tests such as ERCP and endoscopic ultrasound can also be used. So let's review the anatomy of the biliary system. As we know, the liver sits in the right upper quadrant, lying usually underneath the costal margin, and the gallbladder lies on the underside in the gallbladder fossa. The left and right hepatic ducts join to form the common hepatic duct, and at a variable distance down, the cystic duct enters to form the common bile duct. This then runs down behind the duodenum in the posterior part of the head of the pancreas, and then enters into the duodenum to drain through the sphincter of Oddi at the ampulla of Vater. Some points that are worth noting is that the bile ducts within the liver and just outside the parenchyma generally lie anterior to their corresponding portal veins. The ducts inside the liver have brighter walls, they are more echogenic than the vessels, and this in combination with colour Doppler can be used to distinguish between the ducts and the vessels. The common bile duct lies anterior to the portal vein as it travels down towards the head of the pancreas, and we use this relationship to assist us in finding the common bile duct when we're scanning. The gallbladder itself, whilst the neck is relatively fixed and it lies adjacent to the interlobar fissure, the fundus can be quite mobile, and so positioning the patient can often help the gallbladder move to a position where we can see it better. The gallbladder lies in the gallbladder fossa, but sometimes it may be partially or even completely enveloped by hepatic parenchyma. Within the body and the fundus of the gallbladder, one will often see folds as the end part folds back on itself, and this is referred to as a pharyngean cap. The gallbladder is usually an ovoid shape, and the normal measurements are considered to be 4 centimetres in diameter and up to 10 centimetres in length. However, it can be quite variable, and particularly the length of the gallbladder can vary, and sometimes you'll see some very long gallbladders. The wall thickness is up to 3 millimetres, but this is when the gallbladder is distended, and when it's contracted, the wall will often appear thicker than this. The gallbladder itself, if you track down the neck, it then leads into the cystic duct, and within this there are the spiral valve of Hester, which you can see. So, knowing this, how do we actually perform the scan? Well, generally we're going to select our abdominal probe, and we're going to adjust the depth and the focus, and that will depend upon the patient's body habitus and also the acoustic window that we're using. Generally, we'll start in the right upper quadrant longitudinally, and I usually start by sweeping from the midline to the right hand side, aiming up under the costal margin. We ask the patient to take a deep breath and to hold that breath, and that pushes the liver down and can bring the gallbladder out from underneath the costal margin. Alternatively, in particular if the patient can't hold their breath, if we ask them to push their abdomen out, then that also will help depress the diaphragm and push the liver down. If the liver sits very high up under the costal margin, or if there's a lot of gas about, then sometimes we can use an intercostal approach with the probe aligned along the line of the ribs. Now we can do all of this with the patient lying supine on their back, but usually we'll get better views if the patient is lying on their left side in a left lateral decubitus position. And so that tends to be the standard position that we use when scanning the biliary system. Once we have identified the gallbladder, then we can rotate, tilt and fan our probe so that we try and get the long axis view of the gallbladder all the way from the fundus through the body down to the neck. Now, the gallbladder may not lie in one plane for its whole length, and so we may well take a couple of images for the different portions for this. So we scan through the gallbladder in its entirety along its long axis, and then we rotate the probe 90 degrees and we scan through its full length in the short axis. It is important when we do this that we try and trace down as far as we can into the neck, because otherwise we can miss pathology that's localized to the neck, and this is one of the commonest places that we will see stones. To scan the common bile duct, we usually begin by locating the portal vein. We then adjust our probe, rotating, tilting and fanning, so that we are aligned along the axis of the portal vein. And the common bile duct should be sited anterior to the portal vein. Now the hepatic artery also traverses this space, and so it is usually seen up near the porta hepatis, where it runs transversely and crosses between the common bile duct and the portal vein, either the hepatic artery or the right hepatic artery, the branch at that point. But there are anatomical variants, and sometimes the artery will be anterior to the common bile duct. And so because of this, it's generally useful to turn on your colour Doppler box and to just check and see which of the tubular structures is the common bile duct and which is the hepatic artery. Now, the common bile duct can be difficult to see, and so if you don't see it from that window, then the best thing to do is to move your probe more medially and then angle back down onto the portal vein, or move it more laterally and then angle the other way back onto the portal vein, and just try and sweep through that entire area until you see the common bile duct. It can be difficult at times. But once we've identified it, we will then measure the lumen diameter, and we measure inner wall to inner wall. So diagrammatically, this is what we will do. Here is our probe. We start in generally a longitudinal position, and we sweep under the costal margin, having asked our patient to take a deep breath in and hold it until we find the round anechoic filled lumen of the gallbladder. We will then also rotate our probe so it's parallel with the costal margin, and then we tilt the probe up underneath the costal margin and sweep back and forward on the underside of the liver until we find the gallbladder. If we are having difficulty, and we'll often find this in people whose liver sits very high up, then it's quite useful to bring the probe across here, parallel with the ribs, and fan through that window to see if we can see the gallbladder. If we do this, we'll have to increase our depth because we'll be going through the depth of the liver parenchyma to see the gallbladder on the other side at that point. When we do that, what we hope to see is something like this. Here we have the liver, here we have the gallbladder in the long axis here, coming down into the neck here. And this is all anechoic. Here we've got some side lobe artifact over the fundus. We've got a nice regular thin wall to the gallbladder, and so this is a normal gallbladder. We can see a little bit of gas just in the duodenum sitting down here as well, and I point that out because occasionally it can be difficult to distinguish this from a gallbladder that's full of stones and contracted, and we'll talk about that a little further on. We then rotate our probe so that we are now in transverse, and we sweep throughout the whole length of the gallbladder in transverse as well. And here we've got here a shot through the middle of the body of the gallbladder, and here coming up more towards the fundus. And again, the wall is nice and regular and thin. Here in this view we can see there's possibly some slightly echogenic material that is lying in the dependent portion here, and this is probably a little bit of biliary sludge, but it doesn't have any of the bright echogenicity or shadowing that would be seen if these were stones. And we'll talk about sludge a little bit further on. We'll then proceed to image the common bile duct, and so we follow along the underside of the liver until we identify the portal vein, which can be seen here, and running parallel and anterior is the common bile duct. And in this patient there is the classical anatomy, and here we have end on the right hepatic artery that is crossing between the common bile duct and the portal vein. But as I said, there is some variability in the anatomy, and the hepatic artery may be seen anterior to the bile duct in a number of patients, and very rarely actually posterior to the portal vein. This is a zoomed in picture, and we can see again the portal vein, the common bile duct, the hepatic artery, and here we have the calipers measuring from the inner wall to the inner wall of the common bile duct. Now occasionally when you're doing the scan you're going to have trouble finding the gallbladder, and in this situation there's a number of things that you need to consider. The first is, has the patient had a cholecystectomy? This might seem fairly obvious, but sometimes patients may well not be certain, and so you may need to check in the notes and also examine the abdomen for surgical scars. If the gallbladder is shrunken and full of stones, as you often see in chronic cholecystitis, then it can be very difficult to distinguish it from the adjacent duodenum that's full of gas. And in fact, this can be very difficult to tell between the two, and we will show you some examples of this shortly. If the gallbladder is full of concentrated bile, or otherwise called sludge, then the sludge can have the same echogenic texture as the rest of the liver, and so distinguishing between the normal liver parenchyma and the gallbladder can be very difficult, and this is sometimes referred to as hepatization of the gallbladder. A similar appearance will occur if the gallbladder is full of blood or tumour as well. So, having looked for these things, what I would then suggest is, if you still can't find the gallbladder, reposition the patient and try and look from another window. So if the patient's lying on their back, roll them onto their side. If they're on their side, roll them onto their back. If you're looking from a subcostal window, try and look from an intercostal window. You can also remember the anatomy, and if you locate the interlobar fissure, you can then track that down to the underside of the liver, and you know that that is where the gallbladder fossa will be. But whilst most biliary scanning is fairly straightforward, there are some patients that are just very, very difficult to determine where the gallbladder is and to image it. And so, particularly when you're beginning, don't be afraid to say, I'm not sure, I can't see it, and I need help. This is an example of a contracted gallbladder that's full of stones, and instead of seeing the nice round ovoid shape or globular shape of the gallbladder with the walls, the stones here are casting a dense acoustic shadow, so we can only see the anterior wall. The anterior wall is not that nice, even, smooth wall that we've seen before, because this patient has chronic cholecystitis. In this case, we see a very small layer of bile between the wall and the stones, and we can use that to help identify that this is indeed the gallbladder. But some cases are much more difficult than even this case, and unfortunately it's well recognized that sometimes this will be mistaken, in that it will be called duodenal gas or stomach gas, and the opposite situation can also occur. And there are cases where patients have been taken to theatre after having been imaged and had a report of chronic cholecystitis, when the surgeon, when they perform the operation, all they have found is the ligation clips from the previous surgery, because the gallbladder has been removed, and what was thought to be a contracted gallbladder around stones was in actual fact gas in the intestine. This is an example of a gallbladder that is full of a mixture of sludge and, in this particular case, tissue. This is a cholangiocarcinoma, where here is the gallbladder here, but it's full of tissue, and so it's very difficult to distinguish from the rest of the liver. So in conclusion, biliary ultrasound, like all ultrasound, takes practice. Usually the gallbladder is fairly easy to find, particularly if you position the patient properly, get them to take a deep breath in, and have a routine of scanning through that right upper quadrant. When you find the gallbladder, make sure that you scan through it in its entirety, and particularly concentrating on following right down into the neck, because this is where you may miss a stone. Finding the common bile duct takes practice, It's easier if it's enlarged, but it can be particularly difficult in young people where it may only be a couple of millimetres in size. It's also difficult in the obese patient or the patient with a lot of gas where you don't have good ultrasound windows. So I wouldn't expect when you begin that you'll see the CBD every time. And just like everything else in medicine, when you're starting off, you have to expect that there are going to be cases that are difficult, that you're going to struggle with, and that you may not be certain. And in this case, ask for help, find someone with more experience, and get a second opinion. In the next talk, we'll discuss some of the pathology that occurs in the biliary system, and also look a little further into some of the pitfalls that can occur. Thank you.